was very interesting. Thank you, Bill. And thank you for inviting me today and for all of you staying so late, the diehards here. I'm going to talk a little bit about the implications of e-cigarettes for the behavioral health community. And I just want to acknowledge my co-workers, and also that we were supported by a grant from NCI and from through the State and Community Tobacco Control Initiative. I just want to put in a disclaimer. E-cigarettes are not FDA approved. We all know that. There are unknown safety profiles. There's not sufficient data to show efficacy. And I'm not endorsing or suggesting that you recommend these products. I'm sorry. Okay, and what was already mentioned, thank you very much. Somebody said that earlier. Why is it when as soon as you get up here, you suddenly your throat goes?
Because you're tired.
Because I'm so excited to be here. Okay, so there are a lot of potential problems with e-cigarettes, and I just want to make sure that we all are sort of recognizing that we're talking at two different levels here. We're talking about individual level potential problems and also the population level. So what may be good for an individual person may actually be bad in the population. So if you find something that works really well for an individual, good for them, but if at the same time you're sort of being destructive to everybody else in the population, then the overall goal hasn't really been met. So on an individual level, we do not know that these are safe. It is not water vapor, as Phil said. Not all of them are using good product manufacturing processes. So some of the things that are in the e-cigarettes, we don't know if that's because of the processing or if that's innate to the e-cigarette product. And the calls to poison centers are up, as mentioned. So there's lots of ways an individual could be harmed by use. And on a population level, I think one of the concerns, or a couple concerns, one is that use of the e-cigarettes could lead to dual use, so that what that could do is it could prevent quitting among smokers, or they could delay their quitting for a very extended period of time. The other possible population effect that people are worried about is this potential for gateway, so that somebody who's a non-smoker will eventually take up e-cigarettes because they're kind of cool, and they'll like the nicotine that they get from it, and then they'll retire the e-cigarette and go on to smoking cigarettes. And that's a special concern for youth. So I want to acknowledge those problems. And then take it the other way around. So why would we even consider e-cigarettes? We know all the potential harms, but I want to talk a little bit and just get you thinking about some of the potential for e-cigarettes. The first is that e-cigarettes do have the potential to act as a nicotine replacement therapy, and that would make sense. I mean, they provide nicotine, and so theoretically they could play that role. No one's claiming that yet because nobody's gone through the process of doing the randomized controlled trials and submitting that information to the FDA and getting them approved. But theoretically, anyway, it could act that way. So it could help individuals quit. The other thing, because of this explosion of interest, there's the potential that there would be a broader reach. So when you're looking at a quitting aid for somebody, if you come up with like the latest and greatest new thing, and everybody that's a smoker switches from using their patches, and now they're using this latest and greatest new thing, the net benefit isn't very different because most of the products roughly double your chance of success. So you've just switched one population over to using a different product. Population level, you'll still have no additional effect. With something like an e-cigarette or some other product, if it appeals to a broader range of smokers, then that might allow it to be a better quitting aid. So right now, only 30% in the US or so, about 30% of smokers use a quitting aid when they quit. I think in the UK it's closer to 60. But if this has an appeal to the other 70%, then it could have a potential to act as a nicotine replacement. And that could conceivably have a population effect. And then the other reason to consider it is that there is no product likely to be deadlier than cigarettes. They are an extremely efficient nicotine delivery device, very addictive, and combustible products are the deadliest, and by orders of magnitude. But the other thing is that people are looking for kind of a game changer. You know, we have been doing what we've been doing for a long time, and we're having some effect. But the population cessation rates are not changing over the last 20 years. People are looking for something that's going to kind of get us over the hump. And I think some people are looking to e-cigarettes to play that role. There's been some talk about having the FDA start to utilize some of their power to reduce the nicotine levels in standard cigarettes at the same time that they make e-cigarettes more available. And that, again, could be that kind of game changer, moving people away from combustibles. Same thing with pricing. You know, we could end up with pricing cigarettes or pricing products based on their harm profile, and therefore leaving some products, like snus, for Swedish snus anyway, that carry fewer harms, leave that at a lower cost, so that would naturally move the population to the least harm product. And I know that's kind of sacrilege to even talk about least harm, since we should be talking about no harm. But the most important reason for me that I would even consider this is credibility. So I'm a clinical psychologist by training, and all of us have clients and patients that we care deeply about, and it's important they look to us for guidance. And I have real concerns about looking at something that has a lower risk profile and then telling the clients, this is so incredibly dangerous for you. Because to me what that says is, go ahead and use the product that we know will kill you. And don't even consider anything else. Now I'm not, you know, I just feel like my role is to help people think through what this would mean, telling them very honestly about the risks that are there, but not trying to exaggerate them to keep them away from something. I don't think that's my role, and I think it's sort of paternalistic. You know, I know better for you than you know, so I'm just not going to tell you some of this information. That doesn't seem right to me. Okay, so why should we consider the behavioral health population in this discussion? And you guys well know this. There are high rates of smoking. There's both greater uptake of smoking, and there's less cessation that happens among this population. There are high rates of morbidity and mortality, and therefore they really do meet that classification of the tobacco disparity population that Jill Williams talks about. And I think it's important to think about regulations that don't increase the harm, disproportionate harm. So I know everyone wants to get rid of disparities. It's very hard to get rid of disparities. You know, if you're doing something and you're affecting both groups, you can actually still increase the disparities, even though everybody's doing better, because the people who are better off are doing better from whatever you're doing. So things like, things like pricing. So we could take a hard line with e-cigarettes, put in very strong pricing, make them as expensive as cigarettes, and there's the potential to cause disproportionate harm to the lower income clients, because they're the ones who are not going to now be able to use e-cigarettes that actually may have helped them. So I think I want to consider the behavioral health community in part because I think that they run the risk of us increasing the disproportionate harm and the disparities rather than decreasing it. The other issue around that is that why do we consider e-cigarettes and behavioral health? Well, it's already happening. You know that. They're high consumers of cigarettes. The people who are most interested in e-cigarettes are smokers. And I just want to bring some data to bear to this discussion. So I pose the question. So what if a smoker wanted to quit smoking by using e-cigarettes? What are you going to do? What do you say right now? So the data that I'm going to look at is I want to talk a little bit about a pilot program that we did, just looking at the perceptions from clinicians, physicians, and quitline counselors. We actually have a larger survey of all the quitline that has just been finished, so we can get the perceptions of all the quitline counselors, but I only have the pilot here. And then I'm going to talk a little bit about data that we have from a national probability survey, and in that one we focused on those with mental health conditions. And then I want to talk about the clinical implications of that. So this first one was just a very small pilot. We were looking at family physicians at the family medicine department at UCSD. And then we also had 57 cessation counselors. And we had a whole bunch of questions. I'm just going to put a few in here. But one of the first things we asked was, are patients and clients asking you about e-cigarettes? And as you can see, I don't know who the one person was, the counselor, who wasn't being asked that, but everybody's asking. 70% of doctors had also had patients asking about them. And I think it's very interesting that the second one was we asked, well, are you seeking advice on what you should be saying to your clients or patients? And most of the counselors were doing that. The physicians were not. They were just sort of siloed in their little world, curious to know what to do, but not really seeking any outside help. We asked about the belief in the effectiveness of the quitting aids, and I thought these were sort of interesting results as well. If you look at the percent of cessation counselors, most of them disagree that the e-cigarettes would be an effective quitting aid. The doctors were much more inclined to say that they might be, and that may fit with, I can't remember who was talking the other day about, I think it might have been Jill, talking about doctors being more willing to kind of go off-label and maybe use in some other way, whereas quitline counselors have been trained to do a particular thing. We also asked about regulation, beliefs about regulation. Should it be illegal in places where smoking is illegal? Should the use of e-cigarettes by minors be illegal? Should they be taxed like regular cigarettes? And should advertising be banned? And by and large, I only put the strongly agrees here, but by and large, all of these had endorsements that were 80 to 90% of people believed that they should be restricted in these various ways. So the summary of those perceptions is that the e-cigarettes are certainly relevant to the work that we do. Most people are seeing them as not very effective, and I think that's interesting. It's very important to clinicians, especially the quitline counselors, that they are not FDA approved as a quitting aid. And that's their standard. When somebody calls in and they say, well, what do you think about the e-cigarettes? By and large, what they're saying is they are not FDA approved, which the client hears as, you shouldn't do this. So, with very little data to go on, clinicians are erring on the side of being cautious, of being anti-e-cigarettes, which I think is reasonable. I think they should be treated like cigarettes. So the likely answer to that, if a smoker wanted to quit smoking by using e-cigarettes, what would you do? Most would discourage that person from using e-cigarettes. They would offer alternatives to e-cigarettes, such as NRT or bupropion or varenicline. And then they would recommend and provide a referral to behavioral cessation counseling. I think that's what most people would do. But what if, and this is much more common, what if the patient had tried and been unsuccessful with all the recommended pharmacotherapies? And this is true with many people that have behavioral health issues, which I'll show you in a second. What if the person insisted that they would try to quit smoking, but only if they could use the e-cigarettes? And what if the person was unwilling to give up smoking at all, but was willing to switch to e-cigarettes? And I think at that point, you do start trying to think, okay, I can keep to my standard and just say they are not FDA approved, I cannot endorse that, or I can try to do a more patient-centered approach and talk about, what are your fears? What have you tried? Do you know that NRT you can use combination NRT? Actually engage the person in a discussion. So I think what you need to be considering at that point is what's the likely impact of using the e-cigarettes for that individual. You need to weigh the potential to prompt a quit attempt. We've just finished a fascinating study that we haven't written up yet because we haven't had time. But it was looking at sending people patches or sending them placebo patches. And believe it or not, the placebo patches were just as good at getting people to make a quit attempt, slightly less effective as a quitting aid. They didn't have any nicotine in them. But just that, just getting something in the mail that says, okay, go for it, was enough to get a lot of people to try and to quit. So you have to weigh that. Would this person make a quit attempt? You also need to weigh this issue of ongoing nicotine addiction. How do you feel about people being addicted to nicotine? For a lot of people, that's a no-go. If they're going to continue to be addicted to anything, I have to fight that. For other people, I don't want them addicted to a combustible cigarette product. You also have to consider for that individual the potential to delay quitting cigarettes. So that was part of the problem with all the light cigarette, well, there are many problems with all the light cigarette stuff. But one of the things was they even advertised, why quit when you can switch? And so people thought they were taking care of their health. And in the long run, they kept people who would have tried to quit from quitting. So I think we want to be aware of the potential for this. And if you think you can encourage somebody to try to quit, then make sure that they don't stay in that kind of delayed zone for a very long time. Okay, so talk about mental health conditions. So again, high prevalence, more difficulty quitting. Their use of other tobacco products wasn't really known at this time. And we really didn't know much about, do they use e-cigarettes? If so, why? And are they likely to use them in the future? So we did a study. It was a national probability sample survey done through GFK's Knowledge Panel, 10,000 people. One of the things, it's an online survey, but it is nationally representative. So one of the things that they have on each person that agrees to be in this panel is they fill out a profile, a health profile. And so in that, they're asked, have you ever had any of the following, ever been diagnosed with any of the following conditions? And they have ADD and asthma and heart disease and a whole list of physical problems. And then they also had anxiety disorder, depression, or what they called other mental health condition. We did the study early in 2012. We've actually just finished the 2014 where we were able to do a follow-up. And I only just got the data on Wednesday, and it's a very complicated weighting system, so I only have one bit of information from that to show you today. But it's going to be really interesting, I think, because we have what was their status at the initial time. Half the people from this earlier time we got in the second, 2 years later. So we'll be able to actually look at the transitions, how many non-smokers went, or non-e-cigarette users went on to be e-cigarette users. Were the non-smokers, did they become e-cigarette users and then smokers? Did the smokers who used e-cigarettes eventually quit? So it's going to be a very rich data set, I think. But in 2012, this is what we found. So looking at mental health conditions, people who endorsed any of those, by smoking status, and this fits with what probably most of us already know, is that it's highly related to smoking status, so that the rate of mental health conditions in never smokers is much lower than in current smokers or recent former smokers. And this was the use of e-cigarettes in 2012. We looked at ever use, and we looked at current e-cigarette use, meaning use in the last 30 days. And at that time, in 2012, for those with mental health conditions, 14.8% had ever tried, and 3.1% were current users of e-cigarettes. And for those without mental health conditions, it's much, much lower, half or a third. So now look at that to 2014, 2 years later, and you see the same pattern, but the rates have gone through the roof as we kind of anticipated. But again, those with mental health conditions are far more likely to use e-cigarettes, to have used them and to be current users. This one's a little complicated, and sorry. But what I want you to look at is the bottom row, the overall. So what we're looking at is ever use by smoking status. And you can see that the never smokers have very, very low rates of ever use of e-cigarettes in 2012, just 1%. And there's no difference between those with mental health conditions from those that had no mental health conditions in terms of never smokers. It's also very low among long-term former smokers. Those are people who had quit more than a year ago. And that is actually very good news, right? There have been some advertising that's gone out saying, hey, you can manage your anxiety with e-cigarettes, and we didn't know if maybe they were going to end up pulling in non-smokers and people who had been quit for a long time. But at this point, that was not the case. Where you see a lot of the action is in the recent former smokers and in the current smokers. So those current smokers obviously then are dual users, right? They're currently smoking and using e-cigarettes. But there's the significant difference is only among current smokers. So of the people who are current smokers, if they have a mental health condition, they are more likely to be e-cigarette users than those without. So the other thing we wanted to look at was what were the reasons why people were using e-cigarettes? And this actually, I think, reflects a little of our naivete at the time, still calling them e-cigarettes, still assuming that some of the reason people were using them is in reference to cigarettes. So did they think they were safer than cigarettes, cheaper than cigarettes, easy to use when they couldn't smoke, or were they using them to try to quit smoking? And I think we have to expand our thinking quite a bit, certainly with the terminology, the e-pens and the vape sticks and that kind of thing, but also to capture the fact that there's a lot of people that see the advertising, and the more recent advertising is not necessarily linking an e-cigarette to a cigarette. They're not necessarily directing it at a smoker. So I think we're going to have to expand this in the future. But in any case, what we were looking at the time was what were some of the reasons that people were using e-cigarettes, and did those reasons differ based on whether they had mental health conditions? And what we found, they could endorse more than one, which is why the percentages are high. And what we found was that the most common reason was to try and quit smoking. That was what they were saying was the reason that they were doing it. And then followed by, safer than cigarettes or easy to use when they couldn't smoke. But this also we found interesting, that at least at the time when they go to use it, they say they're using it to quit cigarettes. I'm just going to share one of my little fantasies at the time when I found this out. I don't know how many of you are familiar with the blue e-cigs, but one of the things that's very clever about theirs is that it's a little case, and you open it up and you pull out your piece and then you put your cartridge on and it glows blue on the end. But in addition, that little case, if you're within 100 feet of another blue user, it will vibrate and let you know that there's one of your kind out there, and then you can kind of make contact with people, right?
Very bad.
It's very clever.
Very bad.
But I also had this fantasy that what if we were to take back the framing of e-cigarettes, and that they weren't framed as you're isolated from all these other people and you can link up with some other isolate, but that we took it and we created an e-cigarette that was a statement of quitting cigarettes. And so every time anybody saw that e-cigarette, they would know that that would be a statement that, oh, that person's trying to quit, and that person's trying to quit, and that person's trying to quit. Maybe cigarettes aren't a great thing. So that was my fantasy at the time. I doubt that will go anywhere, but... so the other thing that I was looking at, I was trying to figure out, well, so why would the mental health community be more likely to use e-cigarettes? Now, one reason, obviously, is that they have more smokers, and smokers are more likely to use e-cigarettes. But even within the current smokers, those people that have mental health conditions are more likely to use e-cigarettes. So I started thinking, why would that be? And I looked at a couple different things. One is I looked at whether they had ever used any of the FDA quitting aids, FDA-approved quitting aids. And what you can see is across the board, and again, you can look at the bottom one most easily, that having used any of these was much higher for those people with mental health conditions than people without. And so I think the only difference was nicotine spray. There was no difference between them. And bupropion obviously is higher because it's an antidepressant. But you know, they're more likely to use nicotine patches, gum, lozenge, and varenicline as well. And not only that, they were more likely to use 2 and 3 different products. And I think that's interesting because one of the things they're saying is they're using this as a quitting aid. They are more likely to use quitting aids. Therefore, they're more likely to use e-cigarettes as well. And then I looked at the susceptibility to using e-cigarettes in the future. And again, never smokers and long-term former smokers in 2012 was not very high. Higher among the recent former smokers and very high among current users. The only one that's significantly different across mental health status is current smokers' susceptibility. So the summary for that is that they're using e-cigarettes, people with mental health conditions. It mostly appeals at this time to smokers. They use them for the same reason as other smokers. They've tried many quitting aids, and they may be looking for something new. And they have higher susceptibility to using them. So what that brings us to is clinical implications. So what are you going to do? Do you encourage long-term use, short-term use, discourage any use? And I'm sort of going to wrap it up a little bit with these things to think about. And I'm going to take from what Carla was also saying. You have to be thinking about absolute risks. So when you look at, here's a smoker, and they want to use an e-cigarette to quit, what's the absolute risk in that? Well, if it helps them to not smoke, the risk is going to be better, right? If you look at a non-smoker, or somebody who smokes 5 cigarettes on a Saturday when they go out drinking, and they say they want to use an e-cigarette, what's the absolute risk in that? Much, much higher, right? So when you're talking with an individual, you have to be assessing them, their situation, and the meaning of the use for them. You have to look at relative risk, again, how much, what they would be doing otherwise. So if the choice is between being smoke-free and smoking, it's better to be smoke-free. But if it's between vaping and smoking, possibly goes towards the e-cigarette. You also have to be thinking about your own risk tolerance. So some people are risk averse, and so you just want to say, hey, they're not FDA approved, we don't know the safety profile, let's just leave it at that. Other people are willing to go a little bit off-label and talk about that particular person's situation in more depth. You have to assess the likelihood of the person quitting without using e-cigarettes. If you can convince them to use the FDA-approved things, to do combination therapy where they may not have had before, doing more extended behavioral treatment, those things have been proven to be effective, especially for the behavioral health population. And if you can convince somebody to do that, that's probably the right way to go. You also have to work with your patient's belief system. And to me, that seems pretty important. And you have to figure out what your goal is. Are you trying to get people off all addictions, which you may, or are you trying to get them off of deadly cigarettes? And I'm going to probably leave it on this note here. So one of the problems that is coming up is these little sensationalized headlines. So I wrote a paper recently based on the results that I just showed you, and I wrote the press release, so I know it was accurate, and then it went out into the world, into the press, and it was made into all sorts of weird things, including things like this sort of a headline: "Are e-cigarettes good for mental health?" Or the mentally ill are more likely to be using this product. I didn't call them the mentally ill. I didn't say e-cigarettes were good for mental health. But, sometimes when you write something, it kind of goes out into the world with a mind of its own. So be very careful when you're reading to be a very discriminate reader and look to the actual data to make sure that they didn't misrepresent things. And that's it. Thank you.